Hello, everyone. I'm Dr. Oriol Yelamos. I'm attending dermatologist at the dermatology department of Hospital de la Santa Creu i Sant Pau and Centro Médico Tecnon in Barcelona. Thank you for watching this webcast on behalf of the International Dermoscopy Society. Today, I'm going to talk about nevi with peripheral globules. As you all know, there are multiple dermoscopic patterns of melanocytic nevi, and one of these patterns include the pattern of a reticular or homogeneous lesion with peripheral globules. These melanocytic nevi with peripheral globules present with a central part that shows a pigmented reticular pattern or a homogeneous pattern surrounded by a single rim of regularly distributed globules. Typically, these peripheral globules indicate radial growth, and they are the classic pattern of enlarging melanocytic nevi. There are two additional melanocytic nevi patterns that also present with peripheral globules, which include the tear globular pattern and the starburst pattern. The tiered globule pattern presents with multiple rows of peripheral globules, like if we had a tiered cake, and this tiered globule pattern can be seen in spit or red nevi, in nevi of special locations, such as nevi located on the breast or genital area, but also can be seen in melanoma. The starburst pattern presents with streaks or pseudopods, which are actually globules at the end of a bulbous projection, and they are present around the lesion, and they are typical of SPIDS or Reed's nevi, but also in spidoid melanomas. Tiered lesions, tiered globular lesions, and starburst pattern will be discussed in additional webcasts. Peripheral globules on dermoscopy represent the same phenomenon. Actually, they all indicate the presence of radial growth. However, if we focus on nevi with peripheral globules, we know this is a characteristic pattern of enlarging melanocytic nevi. And this study from 2000 by Kidler, they could identify that these globules, the presence of this peripheral rim of globules was associated with growing lesions, and that these growing lesions were more common in patients younger than 20. However, the presence of growth after this age indicated in some cases that there was some degree of atypia, but they could not identify in this series any melanoma. However, these more atypical lesions with this growth and these peripheral globules, they seem to correlate with the presence of BRAF mutations. Here are some examples about this classic pattern of peripheral globules surrounding a reticular nevus. As you can see, the lesion grows symmetrically. Here another example. You can see that the presence of these globules is located surrounding the entire lesion, and that the lesion grows symmetrically. What happens with peripheral globules? So we know that some melanomas actually can present with peripheral globules, especially the melanomas of the nevoid or follicular type. But and that's why we have been classically taught that lesions after the age of 40 that present with peripheral globules need to be excised in order to exclude a melanoma. However, we also know that the vast majority of lesions with peripheral globules excised after 40 are nevi. It's true that some of them, they may have some degree of atypia, but they're still nevi. So which peripheral globules are relevant for melanoma, which indicate our melanoma? What do we do in these cases? In this sense, this group from Memorial Sloan Kettering studied the growth of nevi with peripheral globules in order to be able to see if there were any differences with melanomas. In this case, they only studied nevi, and what they could see is that the growth of nevi with peripheral globules range from 0.4 to 2.2 or 2.3 almost millimeters per month, and that this lesion continued to grow up to almost 60 months. In summary, there was a mean rate of growth of 0.25 millimeters per month, and these lesions stopped growing after 4 to 5 years. When if we compare it, although it's an indirect comparison, but if we compare it with melanomas that present with growth, something that could be seen is that in general, the growth is 0.44 millimeters in faster growth, in faster melanomas, therefore indicating that the horizontal growth rate of nevi with peripheral globules and melanomas is actually the same. So in this case, the speed of growth doesn't really help in order to identify or distinguish melanomas or nevi presenting with peripheral globules. However, what happens if we look into morphology? Is there anything that is different between the globules that are present, the peripheral globules that are present in melanomas and nevi? And the answer is yes. In this large study, also from the Memorial Sloan Kettering group, what they could see is that melanomas were more likely to display atypical globules or tiered globules or globules present at the periphery focally, so not all around the lesion in a symmetric fashion. And only 5 melanomas actually lack dermoscopic melanoma-specific structures as opposed to, so compared to nevi. They conclude that melanocytic lesions with typical and symmetrically distributed peripheral globules and no other concerning dermoscopic features are very unlikely to be malignant. In another cohort, and in this case, a prospective cohort in this study from Spain, they also evaluated 154 high-risk melanoma patients followed using digital dermoscopy and also reflectance confocal microscopy, and they could replicate the same findings. Therefore, lesions that are asymmetrical into axis, that change, or that present with dermoscopic features that are melanoma-specific structures, they then are more, the diagnosis has to always include melanoma, and these lesions need to be excised. Here are some examples from this study in which we can all see that there are some subtle peripheral globules, but those globules are not present all over the lesion. And these, in the second image, these globules are not regular. We see different shapes and sizes and actually some blotches. So not the typical reticular center surrounded by this rim or the single row of peripheral globules. Here, another example in which we can see a lentigo malignant melanoma with peripheral globules in this area, as you can see, but also presenting with additional melanoma-specific structures such as angulated lines. And note that these peripheral globules are located asymmetrically. To sum up, the main differences between nevi and melanomas presenting with peripheral globules are shown in this table. Nevi with peripheral globules, typically they grow symmetrically, they don't present new features or no changes, and most importantly, they do not present with melanoma-specific structures on dermoscopy. Also, the globules at the periphery, they become sparser and smaller, and they eventually disappear, and they stop growing after 50 to 60 months since they enter senescence. However, melanoma with peripheral globules, they typically grow asymmetrically, commonly present with melanoma-specific structures on dermoscopy. These globules do not disappear, and if they do, they are replaced by another melanoma-specific structures, and they don't stop growing since they do not enter senescence. Melanoma typically does not enter senescence. To conclude, peripheral globules indicate radial growth phase in melanocytic lesions. The presence of peripheral globules in nevi is more common in younger individuals, especially under the age of 20. Nevi and melanomas with peripheral globules grow at the same speed, but the presence of a single rim of regular peripheral globules distributed regularly around a reticular homogeneous lesion is most likely to be benign. However, Of course, melanomas need to be excluded, but it's important to know that nevi with peripheral globules can still occur in adults older than 40, but then it's very important to perform digital follow-up to see how they grow, if the growth is symmetrical or asymmetrical, and if they develop any additional dermoscopic melanoma-specific structures. To summarize, melanomas with peripheral globules, they tend to have additional melanoma-specific structures, do not stop growing since they do not enter senescence. They typically grow asymmetrically and also can occur in younger individuals, but however, they have to present, or they typically present, with some of these aforementioned findings. And this is it. I hope you have liked this webcast, and I invite you to review the other webcasts coordinated by the International Dermoscopy Society. Thank you so much.